welcome to the Psychiatry and Psychotherapy podcast. I'm here to talk about getting rid of burnout, increasing job satisfaction, and feeling like an expert in what you do. One thing that created a lot of burnout and angst for me was trying to get continued medical education right at the last minute. So why not join the CME membership and do CME while listening to this podcast? Go to psychiatrypodcast.com, sign up, sign in, take the test, and the certification is emailed to you in seconds. Hi, welcome back to the podcast. I am joined today with Annabelle Kuhn and Dr. Michael Cummings. Annabelle Kuhn was on disorganized attachment, and if you listen to this podcast, you know Dr. Cummings and all the psychopharmacology nuggets he's given us over the years. So today we are going to be talking about akathisia, and I'm excited about this episode because I feel like this is one of those topics that as mental health professionals, we really need to be aware of. It needs to be kind of like on our mind as we're treating patients, as we're starting medications or stopping medications. And so, yeah, welcome to the podcast.
Well, thank you very much. I'm glad to be back.
How about we start with just the general definition, Dr. Cummings? Do you want to sort of break that down?
Yes, essentially, akathisia is a syndrome characterized by motor restlessness, particularly in the lower extremities, involving discomfort in the muscles, often described as an inner sense of jitteriness or tension, an urge to move. It can occur in other body parts, but certainly the lower extremities are the most often involved. Phenotypically, most often what you observe is if people are standing, there's a shifting of weight from one foot to the other. If they are sitting, there is movement of the legs back and forth or rubbing of the legs. It's very difficult for a person with akathisia to sit perfectly still.
Yeah, there's that inner tension, anxiety, panic, irritability, sometimes anger. Sometimes they get more violent, sleeplessness, discomfort. On physical examination, you may see them with these sort of irresistible leg movements, difficulty standing or sitting, rubbing or rocking back, forth, grunting or moaning. Repetitive movements are seen sometimes. And sometimes they get even suicidal in the level of torture that they're feeling internally gets them to a place of suicidality.
Yeah, when I was reading about it, it looks like there's a huge component of subjective inner tension, and it seems like that would be a really difficult thing to experience.
Although he was a somewhat criminal individual, I've always loved Jack Abbott's description of essentially this feeling gnawing into one's bones. That has a rather graphic sort of description that makes you shudder regarding this syndrome.
The quote is, "These medications attack from so deep, the pain grinds into your fiber. You ache with restlessness."
Mm-hmm.
Yeah. Any other historical tidbits you want to throw out there, Dr. Cummings?
Yeah, I did want to note that although we associate akathisia primarily with antipsychotic medications, this syndrome actually was first described well before medication-induced akathisia. Ladislav Haskovic, a Czech neuropsychiatrist, described it in 1901 in 2 Parkinsonian patients. He literally described it, the syndrome, as can't sit still or can't sit down, because his patients routinely had to stand up and walk to relieve the restlessness they felt in the lower extremities.
Mm-hmm. Yeah, and it can be the prevalence is a little bit surprising almost, right? It ranges from 8 to 76% of treated patients, in this one author said, and sometimes it can be described as, an EPS type of movement disorder. But in fact, it maybe should be considered more of a sensory motor disorder because of the powerful sensory component, which is defining the characteristics of the condition. In fact, the sensory component may be the primary problem, with the motor signs being secondary to restlessness and the need to move. I don't know if you have any thoughts on that.
I do. And indeed, I think this is more a sensory motor disorder. And to some extent, I know that the American Association of Neurology has criticized the term extrapyramidal syndromes in the sense that they say, well, these are really very separate syndromes, acute dystonia, Parkinsonism, and akathisia, in their view, really ought not to be lumped together into a single moniker, given that they have very different underlying pathophysiology and very different phenotypic presentations.
Yeah, and it also seems like different antipsychotics produce different extrapyramidal syndromes.
Yes, indeed, and that would agree with the argument that these should not be too tightly lumped together.
So, Annabelle, why don't you take me through the types and characteristics of akathisia and kind of the different types, and then we'll talk about each one, maybe one at a time.
Yeah, sure. So acute and subacute akathisia is sort of what comes to mind when I think about akathisia, like when I've seen patients. And this is described as being what occurs within a few days. So acute and subacute akathisia, the acute akathisia usually occurs within a few days to weeks of starting an antipsychotic medication or increasing the dose. So during the initial weeks, it's considered acute and then later considered subacute. And usually that responds, like you can treat that pretty rapidly when you take away the offending medication.
Before we move on, let's get Dr. Cummings to pipe in if he has anything to add here.
I agree very much with your description. This is the easiest to treat, the most responsive to either withdrawal or reduction of the offending agent, or if that's not feasible because of clinical concerns, then use of an akathisia mitigating agent is most likely to be effective in the acute population. Like many syndromes, the longer akathisia is present, the less responsive it becomes.
Yeah. And then there's, why don't you tell us about chronic akathisia?
Sure, yeah. Chronic akathisia simply is akathisia that's been there a long time, probably several months or more. And this is separate from tardive akathisia, which we'll talk about in a bit.
Yeah. Do you appreciate the delineation between the chronic and acute, Dr. Cummings? Does that inform anything in your mind?
I think it is useful to subdivide these into acute, subacute, and chronic, and that it alters the degree of responsiveness that you're expecting in treating the disorders. Certainly the response rate to either withdrawal of the offending agent or to treatment with a variety of medications is going to be far lower in the chronic akathisia than in the acute. And in fact, almost all of the acute presentations of the syndrome will respond, whereas by the time you get into chronic akathisia, you're often looking at very low response rates.
Okay, let's talk about withdrawal akathisia.
Sure. So withdrawal akathisia or akathisia, it's supposedly indistinguishable from acute akathisia, but this occurs when there's a dosage decrease or like a withdrawal of antipsychotics. And so this can happen when like about 2 weeks after discontinuing an antipsychotic, and it seems to disappear within about 6 weeks.
Yeah, I've seen also there's others medications that when they're taken off, they can potentially produce a withdrawal akathisia. Dr. Cummings, so do you kind of see this as whenever you're getting off of an agent and you develop this internal restlessness? Is this kind of what we're talking about here?
Yes. And indeed, I think what this speaks to, that we'll get to a bit later in discussing the underlying pathophysiology, is that, because we associate it with dopamine antagonism, we tend to think of this, it's a loss of dopamine signal. Actually, it's very likely the underlying pathophysiology is much more complicated, involving derangements and imbalances between GABA signaling, dopamine signaling, serotonin signaling, and not infrequently noradrenergic signaling as well. In fact, despite having been described now for 120 years, it would be fair to say that we still do not have a complete understanding of the underlying physiology or anatomy of akathisia.
So the next one to talk about is tardive akathisia. Annabelle, give us some intro on that.
Sure. So tardive akathisia is a later presentation, whereas acute and subacute happens within days to weeks after starting an antipsychotic. Tardive akathisia usually occurs very late in the course of treatment, like usually after 3 or more months. And it can also occur initially after discontinuation or dose reduction, just like in withdrawal akathisia.
Mm.
Yeah, like the other tardive syndromes, this in some way likely represents a loss of neural plasticity and an inability essentially of in this case, the motor system to reset to baseline, because tardive akathisia may persist for decades after any offending agent is, long gone.
Yeah, and it can sometimes be reduced in severity by increasing the antipsychotic dosage.
Yes.
Have you seen that?
Yes. And if you recall, that's a somewhat parallel to tardive dyskinesia, in which, at least in the short term, increasing dopamine blockade will decrease tardive dyskinetic movement. So in this case, increasing the antipsychotic may actually decrease the restlessness, albeit just as in tardive dyskinesia, the syndrome tends to then reassert itself in a even more persistent, stubborn form if the antipsychotic is continued.
Mm-hmm.
Again, getting back to the issue that this may represent a loss of neural plasticity that essentially results in a permanent derangement of the balance between different neural signals.
It seems very hard to treat. How many people would you say at Patton State Hospital you have with this issue that like you're at any given time, or have you seen in the last 10 years maybe?
We have. In fact, we have some patients almost all the time who have this. Fortunately, it's only a few, and it has declined since we've shifted largely from first generation to second generation antipsychotics. It probably runs right around 1% to 2% of our population. For those in the audience who are not familiar with the California Department of State Hospitals, we're essentially a 7,000 bed forensic hospital system in which 98% of our patients suffer from chronic severe psychotic disorders.
And Dr. Cummings, if you don't know to date, he is the head of the psychopharmacology consulting team. Is that how you would title yourself?
Yeah, I think that's a fair description. I lead a group of a network really of psychopharmacology consultants. Our job is to improve prescribing practices in the state hospital system and to also assist clinicians when they get stuck with some of these incredibly complex treatment-resistant patients.
Yeah. So let's talk about pseudoakathisia. And this is a little bit without their maybe reporting the internal restlessness. Annabelle, tell me what you found out about this.
Yeah, so it seems that this is a term that is used to describe exactly what you said, like objective signs of akathisia without the subjective component. And it seems that there's some controversy about this. It seems like some patients have difficulty expressing this sense of inner restlessness and describe it in different ways. And so it's hard to say for sure if it's truly a pseudo condition, because people experience this discomfort and describe it in so many different ways.
Yeah, Dr. Cummings, how would you say the controversy is, and what side do you side on?
My own bias is that this probably is akathisia, because phenotypically, if you look at these people, they look just like the people with acute and subacute akathisia. If they're standing, they will shift weight, they'll pace. If they're sitting, there's chronic foot movement, leg movement, rubbing the legs, rocking. I think these may simply be schizophrenic individuals in which there is either a loss of connection between the discomfort and the affective response to it, or there is a deficit in cognitive processing of the discomfort. Frankly, which of those is true, I don't know, but I think this is a valid part of akathisia. The other argument in favor of that is it tends to respond to the same treatments to about the same degree as the other forms of akathisia.
And Annabelle, tell us about the last one, this Bing Sicard akathisia. I don't know, how would you pronounce it?
That would be my best guess as well.
Okay.
But yeah, this is akathisia in the setting of Parkinsonian disorders like Parkinson's disease or post-encephalitic Parkinsonism.
Yeah, in some ways, hearkening all the way back to Haskovic and his original descriptions.
Well, let's jump into the causes of akathisia. We've talked about it a little bit, but let's talk about some of the nuance. So let's start with antipsychotic-induced akathisia, because that's the most common. So first generation causes it more than second generation, as Dr. Cummings has said. And of the second generation, what would you say are the highest risk medications and the lowest risk medications?
The highest risk medications are risperidone and aripiprazole. The lowest risk medications are things like quetiapine, iloperidone, and very likely clozapine belongs in that category as well. Essentially, what you're looking at is those medications that are less robust dopamine antagonists or less tightly bound to dopamine receptors appear to disturb the relevant signal transduction less than those things like risperidone or which is a very potent D2 antagonist, roughly 1.6 times as good an antagonist at milligram per milligram as haloperidol, or very potent partial agonists, aripiprazole having a very high affinity for D2 receptors of 0.3 nanomolar.
Okay. Annabelle, anything that you found in the studies?
Yeah, there was this study from 2015. I believe it was a meta-analysis, and it was comparing lurasidone, azenapine, and aripiprazole, and it said that those three actually had the highest risk of akathisia compared to placebo and other second generation antipsychotics.
Yeah. So lurasidone 2.7, azenapine 2.2, aripiprazole 1.5.
Mm-hmm.
And then, yeah, they agreed with Cummings, clozapine, quetiapine as the safest agents.
One comment I would make about lurasidone, interestingly, its very high rate of akathisia virtually vanished when they went from recommending that it be given BID to Q evening.
Yeah, and with food, I've heard it. Do you agree? Dinner time with food is even lowers the risk, or what's the?
Yeah, well, the optimal way to give lurasidone is 30 minutes after dinner, dinner of at least 350 kilocalories. Like ziprasidone, lurasidone requires active transport in order to be absorbed. Not having food on board cuts absorption by roughly 50%. Giving it at night, and this is true for all of the neurologic syndromes with the antipsychotics, if you can give the drug only at night, the person will have a far lower rate of adverse effects because the peak of the drug occurs during sleep. The basal ganglia and the motor system are part of the reticular activating system and basically non-responsive during sleep.
Oh, very good. Very good. See, I just love the little nuance crystals you put out there. Okay. And what about dose? Is like dose impacting because the way that I usually start, let's say, aripiprazole is to start it pretty low, like 2.5 for a couple days. I want to see if they're tolerating it at that dose. If they develop akathisia on that dose, then I know they're going to be much worse on 5. Do you have any sense on how fast things are started and how that impacts?
A general truism in terms of the brain is the brain is far more tolerant of gradual change than of rapid change. So certainly a lower, slower titration will have a lower prevalence of adverse effects than a more rapid titration of the same drug. Intraday variation also counts. The more doses a person takes, the more likely they are to have adverse effects. Probably the best illustration of that, for example, with the dopamine antagonists, is if you compare the oral drugs to the long-acting injectable formulation of the very same drug, same molecule. The injectable, of course, provides very flat plasma concentration curves. On average, while it's the same side effect profile, the side effects occur at about half the rate that they do with the same medication given orally.
And that's true for akathisia as well.
Yes.
Oh, wow.
So lower and slower or more stable is better in terms of the brain.
Very good. Okay, let's talk about anti-dopaminergic antiemetics, such as metoclopramide, prochlorperazine. I've seen it with metoclopramide a couple times. We've been consulted on CNL for these patients, and I've had one outpatient who reacts very, very poorly to both of these, and any antipsychotic she's ever been tried. She's definitely developed akathisia. So I've seen this in practice.
Yeah, I've also seen it with compazine, of course, which is a dopamine antagonist. Sometimes our internal medicine friends forget that while it's listed as an antiemetic, of course, the medications don't read the package insert. And if you block dopamine, you can produce akathisia.
I've never seen, there's two other meds, the reserpine and tetrabenazine. I've never seen those, but those aren't used very often.
Well, yeah, reserpine has fallen so far out of usage that there's probably not enough usage to have cases. I have seen it occur with tetrabenazine because we have a number of people with tardive dyskinesia, and since the newer variants of the VMAT2 inhibitors are so expensive, around $75,000 a year, we still use tetrabenazine in the state hospitals, and occasionally, not as often as with the antipsychotics, we will see akathisia, particularly during titration.
That's helpful. Okay. Let's go to antidepressants. Annabelle, tell us what you found on that.
Yeah, so it looks like SSRIs have more reports of akathisia compared to tricyclic antidepressants or MAOIs, which was surprising to me because I usually think of SSRIs having the least side effects compared to those others.
Yeah. Any comments on that, Dr. Cummings?
Yes. Well, this gets back to what we were talking about with serotonin playing a major role in the modulation of the basal ganglia in this case. There are four major dopamine circuits in the brain. The mesolimbic, which does not have serotonin receptors, but the other three, the tuberoinfundibular, the nigrostriatal, and the mesocortical, all have 5-HT2A receptors on the cell bodies of those dopamine neurons. If those receptors are occupied by serotonin, it decreases dopamine release by anywhere from 30 to 50%. That is, the dopamine signal declines rather dramatically. And, from the standpoint of the basal ganglia, that's not really inherently different than blocking postsynaptic receptors and decreasing dopamine signal.
Okay. Yeah, that makes more sense to me now. That's good. Other medications include anti-epileptics, anticholinergics, calcium channel blockers, lithium, anti-Parkinson's drugs, azithromycin. Any comment on any of those?
They all involve indirectly or directly either altering GABA signaling or norepinephrine signaling or dopamine signaling or serotonin signaling, so that you're looking at those four transmitter systems largely, and what we're finding is that anything that disturbs the balance among this fairly complex interplay of transmitters can cause akathisia.
Have you ever seen it with azithromycin?
Yes.
Oh.
I treated a patient who started taking a Z-Pak for sinusitis. Day 2 of the Z-Pak, the person could not sit still. They were utterly miserable. It was a wonderful case of, well, not wonderful for them, but it was a wonderful example of severe akathisia that was, in this case, related to an antibiotic.
Wow.
Luckily, that does not occur very often. If it did, nobody would take a Z-Pak.
Yeah. Annabelle, take me through the recreational drugs that do this.
Sure. So, yeah, sympathomimetics can cause akathisia, like methamphetamine and also cocaine. Gamma hydroxybutyrate, or GHB, has been reported, as well as MDMA and ecstasy for causing akathisia.
Yeah, again, not surprising, because acutely when people take these drugs, the effect on the dopamine system initially is a huge, gigantic increase in dopamine output. It's gigantic to the point, though, that it causes dopamine depletion. So the person goes from an excess of synaptic dopamine to a loss of synaptic dopamine. And they frankly can look pretty akathetic both at the peak and then at the subsequent trough.
Yeah, there can also be, in withdrawal states, you can have either SSRIs or opiates or benzodiazepines or other drugs. You can have the development of akathisia.
Mm-hmm.
And there was one case that I found of gabapentin withdrawal even.
Yes. And indeed, benzodiazepine withdrawal also can cause akathisia. Again, getting back to the idea that these neurotransmitters are in a very elegant interplay, balanced in a very tight homeostatic range. And anything we do that causes a disturbance of that homeostasis, either up or down, can then lead to akathisia.
There was I don't know if you heard about this case, Dr. Cummings. It's a very public case, so I don't mind just discussing it here. But there was a Canadian psychologist, Jordan Peterson,
mm-hmm.
who was treated with benzodiazepines up to, I think, 4 milligrams a day of, I think it was Klonopin or something, Xanax or Klonopin. And when he withdrew from that, he developed this internal restlessness. And this is what he said: "You would not wish that on anyone. It is unbearable, to say the least. People have been driven to suicidality within an hour. And I had this sometimes 7 hours a day. Imagine someone jabbing you really hard in the rib, and you want to pull away, and there would be a spasm from that, and you would want to move because of that. Well, then imagine that is happening 50 times, and every time you breathe, that is sort of what it is like."
Mm-hmm.
It was just there, and it is there. I could not sit down. I've just started being able to sit down in the last month. That was like months and months later after this started. So it seemed like he had a very prolonged case.
Yeah, it's one of the reasons that if somebody has been taking either high dose, high potency benzodiazepines or very long-term benzodiazepines, it's really important to taper them gradually off of the benzodiazepine. The results of course, stopping too quickly can be numerous, including things like seizures. But one of the outcomes can be a very vicious, essentially what amounts to a prolonged withdrawal akathisia. And he's right. Among all of the motor syndromes that we talk about, akathisia is far and away the most miserable.
Yeah, I think reading his account, it seems like it's even continued to this time. He says it's worse in the morning, it gets better by 2 in the afternoon. Months and months later, and And I think he's off of everything, is what I've heard. Off of every SSRI, every benzo at this point.
Yeah, I think it would be fair to say that he indeed made the transition that we talked about earlier, going from a withdrawal akathisia to now indeed a targeted akathisia. And there are some syndromes in the world that should be on everyone's "I don't want that" list. And tardive akathisia is one of them because it is miserable and it is incredibly difficult to treat.
Yeah. So that is something that we would not wish on anyone. And that's why we're talking about it today, so that we can hopefully put it in your mind to screen for this. And we'll get to how to screen pretty soon. So other conditions that worsen akathisia, Annabelle, any thoughts on that?
Yeah. So it looks like renal disease, diabetes, hyperthyroidism, iron deficiency, anemia, and then Parkinson's disease, as well as peripheral neuropathy. But I wanted to ask about Parkinson's disease because earlier we talked about how like this Bing-Sicard akathisia is like the term that describes akathisia in the setting of Parkinson's disease. But yeah, I wanted to ask if that's like a separate entity or if having Parkinson's at baseline worsens akathisia, or kind of how to think about that.
It likely both makes akathisia more likely, as in the original described cases in 1901, but also likely worsens it as well, because of course in Parkinson's disease, you're looking at the loss of capacity to synthesize dopamine in the substantia nigra and the pars compacta. So in many ways, that naturally occurring pathology was replicated by us much later when we discovered antipsychotic medications. Not that the antipsychotics cause these cells to stop making dopamine, but they do decrease dopamine signaling. And of course, Parkinson's disease is the classic example of loss of dopamine signal. Beyond that, although we think about Parkinson's disease primarily in terms of loss of dopamine, the truth is there is a loss of monoamine synthesis across the board, not to the same extent as dopamine, but in recent decades, we've come to appreciate that Parkinson's disease is a more complex neurodegenerative disorder than people originally recognized.
So we've talked about this before, but how quickly do you see symptoms? It could be days to weeks of starting pharmacotherapy, or it could be when you increase the dose of the pharmacotherapy. So I always like to keep a timeline in my chart of when I increase doses. And so I can look at that when thinking about if this person's presenting with new anxiety, okay, when did it start compared to when did they increase the medication? And then chronic akathisia or tardive akathisia may present months after initiation or dose increase. And so temporal information is very important when thinking about the diagnosis. Anything you want to add on that, Dr. Cummings?
No, I think that's very important. Anyone that you're starting on an antipsychotic should be routinely monitored for the evolution of motor symptoms, including akathisia. Well, my own biases are very much that psychiatrists should first be physicians. We should be doing routine exams on our patient. We should have a blood pressure cuff in our office and a scale in the waiting room, perhaps. And we should be monitoring those physical effects of our treatments that occur. And akathisia is certainly one of those.
Or if you're doing tele-psychiatry like I am, you get them to monitor a lot of those things closely with their primary care doctor, or buy a blood pressure cup if that's something you want to monitor closely.
Mm-hmm. Well, certainly, for example, for many patients these days, since there are automated blood pressure cuffs and automated pulse monitors, they can report that to you.
Yep. So one thing I'd like to talk about is how is akathisia different from other forms of EPS? And so how do you differentiate it from, let's say, dystonias, Parkinsonism, tardive dyskinesias, tardive dystonias? Anything you'd like to talk about there, Dr. Cummings?
I tend to think of the dystonias indeed as being primarily a representation of imbalance between acetylcholine signaling and dopamine signaling at the level of the basal ganglia. Of course, it's characterized by sustained contraction of one or more muscle groups, very often the neck, the jaws, the upper back. Acute dystonia can be very painful, but if you give the person an anticholinergic medication, you can abruptly rescue them from the dystonia, suggesting that this in some ways is a much simpler imbalance to correct than akathisia is. Parkinsonism is, again, loss of dopamine signal. In this case, with some changes in loss of plasticity that leads to both bradykinesia and inability to move or initiate movement, but also over time, usually emergence of things like resting tremor and other involuntary movements that are involved in Parkinsonism, essentially mimicking the characteristics of Parkinson's disease. Usually initially treated with either withdrawal of the offending agent or treatment with amantadine to increase dopamine signal, and for acute rescue, anticholinergics, although given the risks of anticholinergic medications, we really try to discourage people from routine use of anticholinergics because of their risks of causing cognitive impairment, memory impairment, blurred vision, decreases in GI motility, up to and including bowel obstruction and urinary retention.
And long-term increased risk of dementia.
Yes.
It's like, please, guys, watch that.
Yeah. If you have somebody who is suffering an episode of acute dystonia, by all means, give them an intramuscular or intravenous dose of diphenhydramine or benztropine. Don't, however, leave somebody on benztropine for decades when they had one episode of dystonia. I've actually run into cases like that where the person was started on benztropine when they were 20. They're now 50. They've been on this for 30 years. They've had one episode of EPS.
Yeah, I saw that a lot too. And it's like, okay, I'm going to take this off, but get them off slowly. So if they're on like one twice a day, I'll take them down like 0.5 at a, wait a couple weeks, take them down another 0.5. And the parents, are often bringing in this kid and they're like, oh, he's starting to kind of wake up during the day. I'll be a little bit more active. And it's like, yes.
3 months after an acute episode of dystonia, around 70% of people can be tapered off of an anticholinergic with no recurrence of the acute dystonia. So we really don't need to be continuing this for years and years. And in fact, it has turned out that the antiviral amantadine is a much better chronic treatment to prevent Parkinsonism and dystonia than are the anticholinergics.
Very good. Okay, let's talk about the mechanism of action. There's a couple neurotransmitters that we want to look at. Norepinephrine, increased, serotonin, normal or increased, dopamine, decreased or abnormally increased, acetylcholine, normal or unstable, gabapentin, normal or decreased, and glutamate, normal or unstable. That's from your PowerPoint. Anything you want to add on that?
The point in making that slide, this was for a presentation I did a couple of years ago, was to point out that one, the neurotransmitter involvement in akathisia is complex. And that, again, it gets back to the idea of things being outside of homeostasis, but not necessarily in a unitary direction. You see both increases and decreases in some neurotransmitters, or simply a neurotransmitter being unstable, contributing to the pathophysiology.
Yeah, and there's different brain structures where this is involved: the ventral tegmentum, brainstem, basal ganglia, accessory motor cortex.
Yes. Well, I think sometimes we don't stop and appreciate just how complicated our motor system is. Certainly from the BET cells down to the spinal cord is a fairly simple circuit, but that circuit is modified by input from all of these other structures, feeding from the brainstem through the basal ganglia up to the accessory motor cortex. And that's really what permits us to make smooth movements, to initiate movement in a very controlled, fine manner. And that's what we see in these syndromes, is that the person's ability to modulate their starting and stopping of movement has become impaired.
So the next thing we want to talk about is, how is akathisia formally tested? And I think I wanted to go through this kind of slowly and talk about each symptom and things that we might look for and the different degrees. I think this is going to be really helpful for those of us who are in the trenches. Kind of, how do we think through what we're looking for? So Annabelle, why don't you take us through a little bit on this, and then I'll jump in.
Sounds good. So all extrapyramidal symptoms can be tested using the extrapyramidal symptom rating scale, or the ESRS, which was developed in 1979. But if you're looking specifically for signs of akathisia, it'd be useful to use the Barnes Akathisia rating scale, which was made 10 years later in 1989. So I think it might be useful to go through the Barnes Akathisia rating scale.
Yeah, let's do that. Let's focus on that.
Okay. So interestingly, there's two components of it. There's the objective and the subjective component that are both like weighted equally, because the objective motor movements that are occurring are as important as the patient's subjective experience and their awareness of this restlessness. So in order to take a look at this scale, the patient should be observed while they're seated, and then standing while they're engaged in neutral conversation for a minimum of 2 minutes in each position. And so symptoms are observed in other situations too. So like while they're engaged in activity on the ward, that can also be rated. And then the subjective phenomena should be elicited by direct questioning with the patient.
Yeah, let's go through the numbers for the objective. Just maybe say what the number is, and this is like, the higher the number total, the higher the level of akathisia. So let's go through the numbers to kind of show the progression of how this goes.
Sure. So on the objective side of things, the patient would score 0 if it's normal, occasional fidgety movements of the limbs. And then they would score a 1 if there's presence of characteristic restless movements, such as shuffling or tramping movements of the legs or feet, or swinging of one leg while sitting, and or rocking from foot to foot, or walking on the spot when standing. But movements present for less than half of the time that they're observed. And then they would be scored 2 if what I just described are present for at least half of the conversation. And then a score of 3 would be if the patient is constantly engaged in these characteristic restless movements, and or if they have the inability to remain seated or standing without walking or pacing during the entire time.
Mm-hmm. Yeah, Dr. Cummings, any reflections on those? The objective?
One of the things I always do with patients, if I'm suspecting, essentially if I'm trying to decide are they a 2 or a 3 on the objective scale, is I will actually ask them to sit perfectly still and silent for a period of 2 minutes. People who are a 3 cannot do that. They will make it to about 45 seconds, and then they literally begin to look as if they're going to explode. And usually when they hit about a minute, something will begin to move, because by that point, the distress has built to the point they can't stand it, and they get a 3.
I actually had a quick question about the objectivity section of this too, because I was reading and it looks like there's it's not necessarily always the legs that experience this restlessness. And so there's some discussion about whether this scale gives too much emphasis on observing the patient's legs, whereas some people might have akathisia involving their arms or their trunk or head.
I think that's a correct observation. The emphasis for akathisia has always been on the legs because that's how it was originally described. And that is the most common presentation, but it certainly is not the only presentation. Most people I know who use this scale elegantly, if they have a patient and they know that their akathisia is primarily in their head or their arms, they will move their scoring, if you will, to look at those other areas.
So just to be clear, Dr. Cummings, you're saying a 3 cannot stop themselves from moving, like no matter how hard they try?
No, they will begin to look incredibly miserable.
Okay.
And I have, there's probably somebody out there somewhere that can do it, but in my career, I've never met somebody who deserved a 3 who can get it past about 60 seconds of sitting perfectly still.
Yeah, because it's interesting when I was listening to this Jordan Peterson interview. He was talking about at times he felt like he couldn't stop it, but later on now it seems like he can kind of like hold it together for periods of time, but it's really hard to hold it together like for long periods of time.
Mm-hmm. Yeah, he might have declined from a 3 to a 2 with improvement over time, and that's on a practical scale. That's if I'm working with a particular patient and my underlying interest is, are they getting better or are they not getting better? And that's, for me, that's always been a useful signpost that if they can go from not being able to sit still at all for 2 minutes to finally getting to the point where they, their period is getting longer and longer and they can finally make it to 2 minutes, that suggests that they're improving in response to treatment.
Okay. Let's move to the subjective part.
Sure.
So this is the awareness of restlessness. So Annabelle, take us through those.
Sure. So yeah, there's like 2 components for the subjective rating. So yeah, like you said, there's awareness of restlessness, and then the scale also rates distress related to the restlessness, which is an interesting distinction. But so for the awareness of restlessness, a patient would score 0 if there's absence of inner restlessness, or a 1 if there's a non-specific sense of inner restlessness. A 2 would be if the patient is aware of an inability to keep the legs still or a desire to move the legs, or if they complain of inner restlessness that's aggravated specifically by being required to sit still. And a 3 would be if the patient has an awareness of this intense compulsion to move most of the time, or if they report a strong desire to walk or pace most of the time.
Okay.
And then the distress would be rated as 0 is no distress, 1 is mild, 2 moderate, and 3 severe.
The distress related to the restlessness.
Right.
Mm-hmm.
Yeah. Okay. Yeah, and you can see how the misery level is subsequently increased as we go from 1 to 2 to 3. I like to catch people around 1, ideally. And so this is where, if you ask the question with every patient you start on medication, do you have any internal restlessness? Do you have any anxious feelings that are new? Those are very important questions. Dr. Cummings, any thoughts on the subjective portion?
Yeah, I would just encourage people that this is one of the reasons for using a rating scale like this, is to remind us to ask those questions, because many of our patients are reticent to complain. And consequently, if we don't ask directly, they won't say anything.
Mm-hmm. Yep. So we need to ask. And I'm hoping that you, listener, will start to ask these questions, and you will catch some of this, and that will be exciting because you'll be helping your clients. In the Katie trial, it was 30% of non-compliance, or 30% were compliant with medication, right? Somewhere around there.
Yes.
So think about those 70% that were not compliant. What percentage of those had these symptoms and were just like, forget this. These meds are making me worse. These meds are driving me, crazy. And so, if our patients say these meds are driving me crazy, maybe it's like, hey, what does that mean? Let's talk about this. Let's see if some of the side effects are actually the things making things worse. Okay, let's talk about the global clinical assessment of akathisia. This is part of this Barnes akathisia rating scale. I'll put all these notes in my in the handout in the PDF that'll go with this, so you can check this out. Annabelle, you want to take us through this a little?
Yeah, sure. So if I'm not mistaken, is this where you add the score up and then like whatever you add it up to, you can like rate it based on these?
Yes, this part is essentially you as the clinician having gotten the answers to the first three items. You're now making a global impression rating about how severe is this person's akathisia.
Gotcha. So if the patient scored 0 for both parts of the subjective and in the objective component, then akathisia is considered to be absent, and there's like no evidence of awareness of restlessness, and there's no characteristic movements seen on exam either. And then it also says, it says observation of characteristic movements in the absence of subjective report of inner restlessness should be classified as pseudo-akathisia.
Yeah, number 1. So if they scored 1 point total, it's questionable, non-specific inner tension or fidgety movements. 2 is mild akathisia. So this is awareness of the restlessness in the legs and inner restlessness. Worse, when required to stand still, fidgety movements are present, but characteristic restless movements of akathisia not necessarily observed. And so the condition causes little or no distress. That's mild akathisia. Moderate akathisia is awareness of the restlessness as described for mild akathisia above, combined with this characteristic restless movement, such as rocking from foot to foot when standing. The patient will find this condition distressing. And then you have marked akathisia, where it includes a compulsive desire to walk or pace. However, they can remain seated for at least 5 minutes, and the condition is obviously distressing. And then severe akathisia is when they're pacing up and down most of the time, unable to sit or lie down for a few minutes, constant restlessness, which is associated with an intense distress and insomnia. And this is severely distressing, and this is where they might have suicidal thoughts or angry thoughts. Yeah. Any Cummings, want to jump in at all and say anything about these?
Yeah, I just wanted to say that this is a very valuable sort of summary rating in which the clinician can add the other components from their knowledge of this particular patient. Patients cover a spectrum in terms of their willingness to complain. This in some ways gives the clinician an independent opportunity to say, well, this person is maybe a little worse than they're saying, and you can actually rate them higher if you feel that's appropriate. For example, I've actually had 1 or 2 patients who clearly could not sit still, were obviously miserable, but I'm just fine, doc.
Yeah.
Well, no, they weren't.
Yep. And patients want to say they're fine for different reasons. If they think that you want them to be fine and that you're going to like them more if they say they're fine, then they may say they're fine when they're not fine. Or I've seen a lot of patients, they want to report improvement because, that'll make you feel good as the doctor to think that there's improvement going on. We need to look for these objective measures of symptoms as well. So why is this underdiagnosed? That's like kind of one of the questions we were looking at, Annabelle and myself, in preparing for this. And Annabelle, what did you find? Give me the brief summary of why this is underdiagnosed.
Sure. So it seems like there's two major problems leading to underdiagnosis. The first one being that symptoms that fulfill diagnostic criteria for akathisia are sometimes overlooked. And also, conditions that do not fulfill the full diagnostic criteria but can still benefit from anti-akathisia measures are underdiagnosed.
Yeah. Yeah. So I think, like we said before, people often don't ask the questions. People think that they're just anxious. Maybe they're general anxiety disorder. Maybe they get a misdiagnosis of some anxiety disorder, or maybe they get misdiagnosed with like peripheral neuropathy or restless leg syndrome. Whereas, if we did this this Barnes akathisia rating scale, we'd see like, oh, they have a bunch of these put together, and it's leaning more towards this. Any thoughts on this, Dr. Cummings?
Yeah, I think this falls into something that has become true of modern medicine, including psychiatry, is people are often very busy, very rushed, and don't have adequate time to really assess their patients. I think I was reading one issue regarding managed care, and on average, the time spent assessing the patient is now down to less than an average of 3 minutes per visit.
Oh, dear Lord.
So that's, it's like, well, dear patient, tell me in 30 seconds, tell me your relevant history, which is a bit unrealistic. And, that does lead to a lot of things being missed. I know that, the common abbreviation used in medicine for within normal limits is WNL. I think, however, unfortunately, it can also stand for we never looked.
Mm-hmm. Yep. I think it's a challenge for us as providers to not work in a situation where we feel like we wouldn't be able to do the level of care we think is necessary to do good care. Or I think collectively we need to rebel against this shorter and shorter amount of time they want us to see patients in. Somehow, I don't know. I think that's a bigger issue. I imagine if you're listening to this, I have some psychiatrists, because I do coaching now, reach out to me, or just very unhappy in their situation that they're in. And I get it. It's like sometimes there's a lot of pressures to see more people. There's a lot of pressures that are driving people to these shorter visits, but it's not always what's best and necessary. Cummings, any more thoughts on that side?
Well, I agree with you. I think this is a case where we have to be sure that as physicians, we remain in charge of the patient's care and treatment, because, in many ways, we are responsible for our care of the patient. And we can't allow ourselves to be too pushed to essentially do shoddy work.
Yeah. I recently worked with one provider was at an outpatient practice, and they were unable to schedule someone for a follow-up except for like 4 months out. And we talked about not accepting any new patients for a while. Well, that wasn't the policy of the place. And so we talked about how to have a voice, how to have, the ability to sort of negotiate with the place they were at. And they were able to successfully get heard. And they made changes where now they're able to, see patients 1 month after if they want, because they were able to set their clinic up. And I think it's really important for us to realize that the people making the decisions sometimes are not thinking about what's in the best interest of the patient. And we are the patient's advocates. So let's keep going. What are some consequences of undiagnosed and untreated akathisia? So this is kind of venturing into the more difficult aspects of psychiatry, I would say, is seeing that, yes, sometimes our medications can cause harm to people. People can be more violent on these, medications at times, and more suicidal. So, Dr. Cummings, what do you think about akathisia and suicide? What have you seen from the literature?
It certainly carries a substantial risk of inducing suicidal ideation, particularly when you get up into severe akathisia. It is such a miserable condition to suffer from. I think this is another call for us to recognize akathisia early, because again, the important thing is that akathisia in its early acute stages is highly treatable, as opposed to its late chronic or tardive stages where it's incredibly resistant to treatment. We need to have this, as you suggested at the beginning, in the back of our mind. And if someone, for example, is being treated for psychosis and you increase their antipsychotic and they become more restless, more violent, more threatening, the thing that should cross your mind is, could this be akathisia? Or if the person says, you started me on this med and now I have these incredible anxious feelings, again, the thought should cross your mind, is this akathisia? If I push harder, am I going to make this person suicidal?
Mm-hmm. Yeah, I've seen this with specifically with autism. Patients get put on Risperdal. One patient got put on Prozac as well. That increased the Risperdal dose substantially because of the 2D6 being blocked by the fluoxetine, and it increased the Risperdal dose, and the patient develops akathisia and gets more aggressive. And it's like very hard for someone with autism who's nonverbal to express that. But I could feel it in my office. I could literally feel this like inner tension, and you could watch them fidgety and moving around, you know?
Well, I do have to say, one of the things you'll find if you interview very many akathetic patients, when you're sitting across from them and they can't sit still, they're fidgeting, they're rocking, they're shuffling their feet, you'll start to find that you're having a hard time staying still as well.
Oh, absolutely. That's actually how I identify it as someone who's, you know, maybe more empathic and someone who reads my countertransference. My countertransference to these patients is like, I feel like I want to jump out of my skin. And it's just like right there, right away. It's like, wow, why do I feel like I just want to like move around? And so if you have attunement to your own empathic experience, I think you'll feel that. And it's very distressing. Very distressing. The study in particular that I looked at showed that suicidal ideation was associated with observed akathisia in first episode schizophrenia patients who were treated with Haldol or Risperdal. And this was a study of 289 patients. Interestingly, I also found a study where older patients treated, they did not have an association between akathisia and suicidality. So there's a thought that maybe it's like in this sort of newer schizophrenia diagnosis, newer psychotic diagnosis, there was increased risk between these two things. Any thoughts on that?
I think, when schizophrenia is new, it's certainly a horrible disease. And I think something that we don't appreciate, if you say major depression, people think, oh, suicide risk. The suicide rate among people with schizophrenia is actually higher than among people with major depression. Not only are these individuals going through incredibly difficult changes in their thinking, their perception of the world, but if we add to that a very distressing sensory motor syndrome, it makes sense that it is going to be very difficult for them to deal with. I think in the older schizophrenic patient, they've often adapted to some extent to having a chronic psychosis and are more tolerant of many adverse effects than a younger patient is.
I had heard of like this interesting case where our patient was admitted to the inpatient unit and was complaining of a tremor, and was admitted because he was on flufenazine, which was prescribed a few months prior, and he was complaining of this tremor that made him want to cut his arm off and die by suicide. And it was interesting because there weren't any other signs of akathisia, but it looks like akathisia is the only extrapyramidal symptom associated with suicidality. So,
yeah,
interesting
indeed.
case there. Yeah.
Yeah, indeed, Annabelle. If you have a patient who says, I have this movement symptom, well, if that's all they say, then you're probably not looking at akathisia. You're probably looking at a dystonic tremor or some other motor symptoms. But if they say, this thing is moving, whether it be their leg or their foot or their hand, and it's driving me crazy, and I would rather die than have this continue, you're likely looking at akathisia in some form.
I want to talk about akathisia and how it increases aggression, can increase homicide risk. This seems to be a pretty triggering topic to even think about for us as providers, that we would give something that would increase someone's aggression, increase their risk of killing someone else. I found this case study of 10 patients who had attempted or completed suicide, homicide, who were found to have these P450 mutations that might have increased the dose of the medications that were given and caused akathisia. This is Lucre 2011. Are you aware of this study, Dr. Cummings?
Yes, I am.
Is this study like, does it have holes in it? I mean, there's a lot of details in it. I'm just wondering, as a forensic psychiatrist, if you look at this and you're like, yes or no, or like how you view this.
I think so, some of the details may or may not be correct, because so far this has not been replicated. However, I think the general observation that akathisia can drive not only suicidality but increased violence is definitely valid, because that has been replicated in the form of a variety of correlation studies. And in some ways, it's not surprising if somebody is suffering from a condition that makes them physically miserable, if they are all prone to aggression, loss of impulse control, making them increasingly miserable certainly does not help limit their probability of becoming violent.
So the study really pointed out there's issues in like 2D6 that lead to, increase in the nortriptyline or Paxil or Prozac, that are broken down by 2D6. They describe case study after case study of this occurring. And when I'm reading some of these case studies, it almost looks like some of them were more delirium, or like the confusion level or the lack of memory of what happened there were some gaps in memory. And so one of my thoughts and questions for you is like, okay, so is he describing akathisia or delirium in some of these clients, who had very anticholinergic medications as well that were obviously very much high in the level, potentially due to the mutations, due to not having these genes?
And the answer is it may be both. Certainly for anticholinergic medications, those impair cognition and memory. But ramping someone's affective state up to the point where they become overtly violent also tends to impair memory function outside of people with mental disorder. If you do a survey of people who've committed very violent crimes and ask them to give you a detailed timeline of the crime, only about a third of people who've committed violent crimes can actually give you an accurate timeline. When they are very effectively aroused, people don't record and consolidate memory accurately.
Interesting.
And for some of these individuals who are already suffering from a psychotic disorder, meaning their thinking may not be all that organized to begin with, if we do something to them that makes them more miserable to the point of becoming affectively aroused and violent, in some ways it would not be surprising if their memory of that event is less than crystal clear.
Okay. So let's talk a little bit about similar or linked pathologies. And I know you had mentioned before restless leg. I wanted to get your take on this. Is it similar in how they both have increased tension, anxiety, restlessness? Is the same thing going on? And how do you differentiate them in your mind?
Similar and different. Things that are different that can help distinguish them, because that's often clinically what we're interested in doing. Akathisia occurs about equally in men and women. Restless leg syndrome is somewhat more common in women. Restless leg syndrome is also more common with advancing age. things like iron deficiency, for example. Restless leg syndrome presents with paresthesias, which akathisia does not. And probably the most telling thing about restless leg syndrome is that it is almost always in the evening and then tends to resolve during the daytime, whereas, of course, akathisia can be much more 24/7. So there are some important phenotypic differences. In terms of the pathophysiology, they are probably somewhat different but related in that we only have a certain number of neurotransmitters involved in the ventral tegmentum and basal ganglia. In the case of restless leg syndrome, we're probably more purely looking at either things like iron deficiency, which alters basal ganglia functioning, or things like dopamine deficit, because indeed one of the key treatments for restless leg syndrome, of course, is a dopamine agonist at bedtime.
Okay. Yeah, those are helpful. And we'll have more notes on this in the handout. Getting to the treatments that are supported by evidence. So once you have decided through, testing and observation that this person has akathisia, the first thing I think about is decreasing the offending agent. So thinking about historically what happened, reducing the dose. And I also think about okay, how do I acutely, if they have very high symptoms, how do I acutely make them feel better? Beta blockers like propranolol, 40 to 80 milligrams a day, mirtazapine, 15 milligrams a day. Now, you taught me that a couple of years ago when you were on, and it's been very helpful. And actually, I had one patient who, when I tried to take him off of mirtazapine, he got restless. So I think it was actually protecting him, some of that underneath. And then those are the main ones I think about, propranolol or mirtazapine or a benzodiazepine, like a long-acting one, lorazepam, clonazepam, diazepam.
Yeah, indeed, the data in terms of the amount of data that's available is best for the beta blockers, propranolol being the most common. Metoprolol, less data, but it does appear to be effective. Mirtazapine actually is more effective than the beta blockers at 15 milligrams at night. That's the only dose that's been tested, probably due to its ability to block 5-HT2A receptors. Also in that same vein, things that block serotonin signaling, miancerin 15 milligrams, or cyproheptadine 8 to 16 milligrams have also, in much smaller data sets, have been shown to be useful.
Yeah, there's a couple, it seems to be emerging medications for akathisia, N-acetylcysteine. There was one 4-week study that compared 140 patients with schizophrenia. They had 84 completers with 1 gram twice a day of N-acetylcysteine versus placebo. And there was a moderate reduction in akathisia with N-acetylcysteine. Any thoughts on that being an option?
It appears to be functioning as an antioxidant and may be protective over the longer term. The effect, as in the study you described, was not as acute as with either beta blockers or serotonin blockers. It was a more sustained, gradual effect. So, N-acetylcysteine could possibly be a protective agent in some patients. Say you have somebody who clearly is sensitive to developing akathisia, you're going to have to put them on an antipsychotic long term. N-acetylcysteine might be a way to protect them as they're taking the antipsychotic. Same thing might be true of very high dose vitamin B6, which also has very modest data to suggest that it reduces the prevalence of akathisia. And then we also have data from some non-benzodiazepine GABAergic agents, things like gabapentin, which of course is FDA approved for restless leg syndrome. Well, not surprisingly, it also has shown some efficacy in treating akathisia, as has pregabalin.
Okay, very good. Well, this is coming to the end of our time, and I just want to maybe give a moment to have any final remarks. My final remark would be please screen your patients for restlessness, at least asking them since have you been feeling restless? Have you felt, and the second question, if they said yes, does it help to walk around or do you feel like you're moving around more? And then if they're restless looking and they might report restlessness, either one of those, going through the Barnes Akathisia rating scale is, I think, very important. And so once you have that diagnosis, then think about when it started, so what type it is, and what was the probably most likely offending agent. Can you decrease that agent? Can you switch to another agent? So for example, if they're on a Risperdal or something like that, could you switch to Seroquel, Clozaril, or Zyprexa? Would you put Zyprexa in there, Dr. Cummings?
Yes, I would.
In that category? Okay. And, could you switch them? Could you decrease them? Could you add a propanolol to, decrease their just tension in the moment? Do they have such severe symptoms that they need a benzodiazepine? One patient in my partial program, when I saw her, it was so bad that I immediately said, go to the pharmacy right now, pick up Klonopin, take it today. It was that bad, Do not wait till the end of this 8-hour group therapy. Go right now. So the urgency on this is pretty high. And then see them frequently. You need to see these people, multiple times a week sometimes, just to make sure this is being improved. The other final pearl that I would put out there is, after you start a patient on a medication, they need to be able to feel like they can get a hold of you. So this is like the one thing that I warn patients on when I start them on any medication. Like, hey, if you feel more restless, please reach out to me sooner than later. I don't mind an email. I don't mind a phone call, and please reach out to me because we need to talk about it, and get them in that day and talk to them for 5 minutes or 10 minutes and figure out what's going on. So those would be my sort of closing remarks. Annabelle, do you have any?
I think, after looking at all the information, it's really important to catch this early, like you said, and consider it every time you're starting an antipsychotic or increasing the dose.
Okay, here's my question for you, Annabelle, okay?
Yeah.
You're at Harvard. You see that a person has akathisia, and you bring it to your attending, and your attending shoots it down and wants to increase the antipsychotic. What do you do next?
I would ask them why they think it's not akathisia.
I've been practicing for 10 years, Annabelle, and I know that this is not akathisia. This is anxiety. They need this antipsychotic.
I think at that point, I'd probably, print out the Barnes akathisia scale and say, maybe let's take a closer look at it and really, really kind of press that. I'm definitely not shy to stand up for what I'm thinking. And maybe I am wrong too. But it would definitely be interesting and important for me to explore that and challenge that.
Yeah. No, I was going to say, because I know that there's people who are listening to me who have emailed me, and they're like a psych nurse. They're like, how do I communicate this with the attending? Or one person was even just working in a psych hospital. They didn't have like a title, like a nurse or a physician, but they were catching people with this issue. And I said, call the attending, talk to them. But I think that when I was thinking about this right now, print out the Barnes akathisia scale, circle what you see, and then bring that to the person in authority, hand that to them and say, hey, here's what I see with this person. I'm new to this. Hey, help me understand what's going on. I think that they just started this medication. Could it be from this? I'm worried that they might have this really severe restlessness. I don't know. Dr. Cummings, any thoughts?
Yeah, I think those are definitely worthwhile. The other thing I would add as a closing comment is, for any of our clinicians, if you start a medication that can cause akathisia, which we've gone over those during this hour, the antipsychotics being the primary group, but also SSRIs and some others like calcium channel blockers, some antibiotics, and the person appears restless, you should do two things. One, review the person's medication list and be sure that you're not giving them a drug that inhibits the metabolism of the newly introduced drug. And two, consider obtaining a plasma concentration of the potential offending agent. You may be looking at a much higher plasma concentration than you expected. There are people who are very poor metabolizers for a whole variety of drugs. And consequently, you may be seeing this as an adverse effect, even though you're thinking, oh, it couldn't be, the dose is so low. Something I've said before on this program is dose is a very, very poor guide to the adequacy of treatment. If you're in doubt at all, get a plasma concentration.
Yeah, 100%. But I would also add, Dr. Cummings, how long do you wait for that plasma concentration to come until you take action if someone is in the more severe range?
Oh, you take action immediately. The lab, as most labs are, is simply confirmatory. I personally am very much opposed to people practicing by laboratory data. The purpose of most labs is to confirm what you already know clinically. One of my criticisms of current medicine is too many of us and our colleagues have become overly dependent on lab data. If you have an abnormal lab in your hand, the first thing you should do is go look at the patient.
Yep. Very, very good. I run this program for people with medical and psychiatric issues in California still. And one of the patients recently came with severe anxiety after the tidal volume was dropped. She is on a chronic trach. I corresponded with the physician who had been treating to her ABG and not her subjective symptoms. And one thing that we know from like yoga breathing or relaxation breathing is that big tidal volume breaths are actually very calming. And short tidal volume breaths can be anxiety provoking. And so I provided some articles and evidence for that. And she actually took my evidence and it cured the issue. But I think it's just a testament to that, like the subjective experience of the history taking and our knowledge is very, very important. Labs, I like how you said it, they can confirm, but shouldn't guide necessarily us unless, obviously if they're hyperthyroid and their T4 and T3 are way, way high, It's like, yes, of course, that needs to guide what we do. Any other thoughts on that, Dr. Cummings?
No, I think that pretty much does it for me.
Okay, well, thank you so much, Dr. Cummings, Annabelle, for helping me put this together. I think that the people who listen to this are really appreciative, so I'm appreciative of your time and effort, and we'll get this out there soon. And we'll leave it there.
Okay, great.